All right, we're going to go ahead and get started. Welcome to the Ask the Experts COVID-19 virtual town hall. Thank you for joining us to hear about the current issues at Chapman in our community and to hear from a wide range of experts. Hope you all are well and safe. My name is Tom Piechota. I'm the Vice President for Research here at Chapman, and I'll be moderating the town hall today. This is certainly a timely discussion given what we're hearing in the community. This has been going on a long time. But as we open up different activities, whether that's our schools, our businesses, we're hearing a lot about vaccines. We hear a lot about boosters, whether we may or may not need those. Actually, we were set to roll out boosters next week, so you may hear some of that discussion today from our experts. Then, of course, about different variants in our community or in our communities and the ability for vaccines to work against different variants. So we've got a wide range of experts to hear from today. As I said, Chapman continues to monitor these conditions and create a safe place for our students, faculty, and staff. And you hopefully joined some of the town halls last week to talk about those specific issues about Chapman. What we're here today is to talk about the broader community issues, whether that's the broader science around vaccines, the broader policies, public perceptions, and the different experts to address those. We want you to join in and ask a lot of questions. So there's a Q&A feature that you can post questions to as the different experts are talking, and we'll get to as many questions as those as possible. So with that, let's go ahead and get started. And I will get started with introducing our first expert. Our first expert is pretty well known at Chapman. He's involved in a lot of these town halls and he's involved in our community also. This is Dr. Jeff Goad. He's the Associate Dean of Academic Affairs and a professor and chair in the Department of Pharmacy Practice at the School of Pharmacy. He's kind of our go-to at Chapman for all things around COVID and vaccines. So we're really thrilled that Jeff's able to join us today. So Dr. Goad.
Great, thank you. So let me get started and thank everyone for joining today. I know we've talked a lot over since the pandemic started about different aspects of COVID, vaccine now, and as well as the epi. So I kind of want to bring people up to date where we are in Orange County, especially where our Orange campus sits, and kind of think about the statistics and the epidemiology around us, and then end off with a little bit about the vaccine and where we may be going, which I think will end up with a lot of questions coming forward about boosters and the fate of COVID vaccine going forward. So first off, just to give you a little update where we are, we continue to see increased cases in the younger population, so around the 35 to 45 range over here. And we tend to see less in the older population. If you remember at the beginning of the pandemic, this curve was inverted and we saw a lot more in our older population. This has a lot to do with our extraordinary vaccine efforts early on in our skilled nursing facilities and other assisted living facilities for our older adults. So we tend to see now is a younger population. And I think Dr. Fong will talk a little bit more about what the hospitalized patients look like too. Now, on the data that you'll also start seeing on the Chapman website, these are two of the metrics that are very important. The first is the adjusted daily case rate. So we're at about 15.3. These colors here, purple, for example, relate to what now the county is using is a CDC tiered system to help to understand whether we're in substantial spread or widespread or a lower amount of spread within the county. And we're right now in the second to lowest tier. The way the numbers are trending, we're at 4.7% 7-day average, 7-day lag percent positivity. Those are percent positive cases resulting from tests that we do. So looking at the number of tests that we do in the county, the percent positivity overall is 4.7%, which is down. So we are trending down, but there is some differences in the individual places within Orange County. And Orange is one of those exceptions where our Chapman University sits in there. We sit at an 8.5%, almost double the county's rate right now with a 17.6 7-day average case rate, right? Looking at the vaccinated population side, we're also a little less than the entire county at 57% of those less than 65. Those over 65, much higher, over 80% vaccinated. So we do very well with our older population getting vaccinated, but not as well with our younger population. And then I just want to point out down here, who's given all the vaccine in Orange County? Well, it turns out the number one giver of vaccines was the county health officer, or the county of Orange themselves, primarily because they had all the vaccine at the very beginning. And they were doing Angel Stadium or Disneyland and all these big events. But after that, and what we continue to see is that the community pharmacies, so CVS, Walgreens, for example, are the number 2 and 3 vaccine givers within the county. Now, I think it's also important as we get into issues talking about the vaccinated and the unvaccinated. Certainly, we don't have everyone vaccinated yet, but the data is pretty clear. This is looking at your 7-day case rate, whether you're vaccinated, right, which is down here in this pink color, or you're unvaccinated, which is in this green color. We can clearly see that the vaccinated fare much better in terms of getting COVID, 6 times better, really, than the unvaccinated. So we have great data that shows that getting vaccinated does protect you. And then over here, this is looking at how well we've been doing. At the beginning, when vaccines were licensed, we were administering a lot of vaccine. But as you can see now, as we move in July, August, into September, that rate has dropped off. And a lot of it has to do with when people look at the numbers and they see them falling, they don't come in as often to get vaccinated. We know that Orange County right now, there's 3.1 million residents. We have about 61% are fully vaccinated. We've given 3.8 million doses to our Orange County residents, but we continue to see some disparities in different ethnicities. So for example, the Asian and Caucasian groups, which represent a less than the Hispanic population percentage of the OC population, tend to vaccinate more of that population. Where we do lag behind is in our Hispanic population, who represent a very large, the second largest percent within Orange County, but are one of the lowest percent vaccinated. So we still have disparities within the county that we need to work to close that gap. Lastly, how's our vaccine doing? I think this will lead into a lot of our discussion. We all saw the data when it came out early from January to March, at least in healthcare workers, with a 94% vaccine effectiveness against symptomatic disease. And I know some people keep saying we're moving the goalposts. You talked about symptomatic disease, and now we're focusing here, for example, on June to August on severe disease, like those that would end you up in the emergency department or urgent care. So now we see a lessening of the vaccine effectiveness all the way down to 77% for Pfizer. Moderna is holding in there a little higher at 92%. But for hospitalizations, we continue to see very high protection for people from being hospitalized. But we do notice that it is less than it was before. Early on, when the vaccine was licensed, we estimated it was around 99% protection against severe disease and deaths, at least in that MMWR publication. But now we're downwards around 80%, still 95% holding in there for Moderna. So that overall, it looks like at our interim estimates, we're about 86% protection from vaccines in general against hospitalization, and about 82% at severe disease that would end you up in the emergency department or urgent care. I'll go ahead and stop there. I think that's enough to spur on some discussion later.
Right. Well, great, Jeff, and thanks for that, the background on giving us kind of where we are with the numbers, and that's really helpful to kind of set the context. I want to introduce our next expert, Dr. Jennifer Totonchy. She's a returning expert to our Ask the Expert town halls. She's an assistant professor of immunology and immunotherapeutics at the School of Pharmacy, also at our Irvine-Rinker campus. And she's going to talk to us some about the science behind this and why it's important to get vaccinated. So, Dr. Totonchy, I'll turn it over to you.
Thanks, Tom. So I teach immunology. I also teach vaccine formulation. So I'm happy to field questions related to either of those topics here. I just had a couple of things that I wanted to address in these short minutes for remarks. 2 concerns that I hear a lot from people who are hesitant to be vaccinated that directly speak to my expertise in immunology. So the first of these two concerns is that these variants of concern that we're seeing with the COVID-19 virus are eventually going to make the vaccines useless. And why would I get vaccinated if the vaccine is just not going to work because a variant's going to come up? And I'm showing you this picture because it's going to be pretty obvious to us looking at this picture that all of these panels are the same person. And the reason that we can see that all of these panels are the same person is because our brains are really highly adapted to recognize faces. And we recognize faces by looking at multiple aspects of a face simultaneously in order to be able to compare what we know from one picture to the next. And it's very easy and very intuitive for us to say, these are all the same person, even though they have differences that we can also see. Our immune system is very highly adapted to recognize proteins. And this is the spike protein from the COVID-19 virus that the immune system is trained to recognize when we get the vaccine. And this panel over here on the left is the original spike protein that was made by the original vaccines. This picture over here on the right is the spike protein that's being made by the Delta variant. And you can probably not very easily see the difference between these two. And it's because they're very similar. And our immune systems are highly adapted, just like our brains are highly adapted, to recognize differences and similarities between protein structures. And so the immune system uses multiple portions of this protein to recognize and target and prevent this virus from being able to infect our cells. And so by just changing the red part, we are not, see, this is the red part that's substantially different between these two pictures. This isn't going to change the fact that the vaccine trains our immune system to recognize this part that doesn't change, or this part that doesn't change, or this part that doesn't change. So these very small pieces that are changing, they're having a profound effect on how the virus functions, but they're not having a profound effect on the ability of our immune system to recognize this protein as this virus. The second concern that I hear a lot is this idea of booster frequency, right? And are we going to have this yearly? I don't want to have a COVID vaccine every 6 months or a COVID vaccine every year. And I'm bringing back this one face to remind you that just like our brain might have to see this person 3 or 4 times before it would very easily and very quickly recognize him just seeing him on the street, our immune system needs to see that spike protein several times before that recognition is really, really powerful, right? And this is just how the immune system works. It provides more resources in recognizing and remembering things that it has seen multiple times, exactly like our brain memory. So it's really not actually surprising to anybody in immunology that we have to have boosters for the COVID-19 vaccines. The reason we didn't know originally how many boosters it was going to take to get that really robust immunological memory was because we were just doing this as fast as possible to save as many lives as possible. And optimal boosting frequency is one of the things that usually happens in the 5 to 10 years that it takes to develop a vaccine. This image is the pediatric vaccine schedule, and you can see that the vast majority of these shots, you get them more than twice. And these boosting schedules have been optimized over many years to make sure that children have effective memory responses against these disease-causing organisms. So we're figuring out sort of as we go how many doses of the COVID vaccine it's going to take to get really robust memory. But it's not going to be yearly the way the flu is yearly. I would argue that flu vaccines are not boosters. It's a new vaccine every year because the virus is a new virus every year. And the virus that causes COVID-19 is not like flu in that way. It doesn't mutate as fast as flu. It doesn't have as many tricks up its sleeve as flu does to make itself different on that time scale. So most likely, we're looking at a 3-dose, maybe 4-dose maximum, and then everybody will have a really durable immunity and long-lasting immunity against COVID-19. And with that, I'm going to pass it off to Tom and the next panelist.
All right, great, Jennifer, and thank you for those remarks. And giving some of the context in terms of, and starting to answer actually some of the questions that people have probably around boosters and the likelihood of that also. So thank you so much. We're going to shift gears a little bit here and introduce our next speaker, who is Michael Shermer. Really thrilled to have Michael. Michael is a presidential fellow here at Chapman. He's been here since 2011. And he teaches a really interesting course for our students, our freshman students, around Skepticism 101. This is affiliated with our first year foundations program. And Michael certainly brings a different perspective to the discussion here. And I think you'll really enjoy hearing from him. So Michael, it's all yours.
Okay, thanks everybody. Yeah, so this is my day job here, publishing this magazine called Skeptic. We deal with a lot of different subjects, mainly on the fringes of science and alternative medicine and quackery and pseudoscience and the like. And we've been dealing with what used to be called the anti-vaxxer movement. Now it's called the vaccine hesitancy movement. But by any other name, it actually goes back to the late 19th century and the concerns about injecting a portion of a disease as a way of tricking your body into being inoculated against it is, kind of taps into a deep human emotion of disgust. Most of our disgust emotions are around things that are associated with disease carrying agents. And so there's a good evolutionary reason why people kind of have a natural taboo against doing something like that. Nevertheless, with education and enough public health information, most people are able to overcome that. But as we've seen in the recent round, not so much I think for three different reasons. This pandemic is new in terms of, it's the novel coronavirus. It's new for our generation. And, it's been a century since we had something like that. So there's no personal or institutional memory to tap into immediately on that. So there's that. And then there are of course, always inevitable side effects that all vaccines have. But here it's a peculiar misreading of risks. There's the risk of the vaccines, of course, but they are far outweighed by the risk of getting COVID-19. And it's astonishing that people have a hard time keeping those in perspective. Here's some of the analogies I made here, my article for Skeptic on this. According to the National Highway Traffic Safety Administration, 38,680 people died in automobile accidents in the United States in 2020. By contrast, 345,000 people died of COVID-19 in 2020. So it's an order of magnitude higher. And yet few people give a second thought to hopping in the car and going for a drive, many while texting, eating, drinking alcoholic beverages, and fiddling with sound and navigation systems. So, again, it's just kind of a misreading of the risks. The risks themselves are minuscule. According to the CDC, the rate of anaphylactic shock from the vaccines is roughly 2 per 1 million people. By contrast, according to the CDC, the death rate from lightning strikes in the United States is about the same. So you have the same chance of dying from a lightning strike as you do from going into vaccine anaphylactic shock. And if you sit there for the 15 minutes that they have you sit there after you get your vaccine, just in case you go into anaphylactic shock, you're not going to die from it because they can save you right there. So even that risk is nothing. Let's see, according to the CDC, the Moderna vaccine, there was 2 confirmed cases of thrombosis or blood clotting out of 328 million doses. So I calculated that to be roughly the equivalent of getting struck by lightning 300 times in a year. Okay, so the side effects are really just minuscule. And even if you took the worst case scenario of the worst report of how many people have died from the vaccine, 6,490, even that's probably an order of magnitude too high. Even that would be roughly, again, about the same rate as being struck by lightning when you compare it to the 346 million doses of the vaccines that have been given. So we have a kind of a misreading of risk. And yet, if you educate people on this, you just kind of explain the relative balance between the two, the COVID-19 or the vaccine themselves, and they get used to the idea, then they can switch. And that leads to my last two. Objections political. This whole thing has become political. It's unfortunate, mainly on the Republican side. Democrats are far more likely to get vaccinated than Republicans. And, that didn't used to be the case, in the 1950s with, polio and some of the other vaccines. Conservatives, Republicans were behind that. But I think in part because of the polarized nature of our political system now in the last 20 years or so, the idea of associating vaccines with something that the government is telling you have to do. And that leads to my third point, which is people have a misunderstanding of what freedom means, because you'll often hear people saying, well, I should be free not to have to be vaccinated. Yes, okay, well, are you free to drive on either side of the road that you want? Shouldn't I be protected from people driving on my side of the road? So again, it's just what we get used to because we're used to wearing motorcycle helmets and seat belts and things like that. And no one's talking about seatbelt hesitancy. And so there's no reason why we can't get there with that if we have a proper understanding of what that means to be free. I should be free from your germs, just like you should be free from my crazy driving.
All right. Thank you, Michael, and thank you for those comments. And I think it'll spur lots of nice, good questions. And then I want to introduce our last speaker. Going back to our faculty at the School of Pharmacy. Our last speaker is Gary Fong. Dr. Gary Fong is an assistant professor of pharmacy practice at the School of Pharmacy. He teaches infectious diseases and clinical pharmacokinetics. He's on the ground working in the clinics, working in the hospitals. So I think he's going to bring a unique perspective in terms of what he's seeing as he's working out there in the field. So with that, I will turn it over to Dr. Fong.
All right, thank you very much. Good to be here with everyone. So yeah, I'm hoping to shift gears a little bit and talk about a different aspect of COVID, but still somewhat related to vaccines. That's both what's going on in the hospital, but then the therapeutics that we have as options for treating patients once they do get COVID. So again, I'm up at Harbor UCLA Medical Center up in Torrance, and we're a county hospital, and we've kind of gone through the COVID waves as you would expect from an LA County perspective. So the first thing I wanted to talk about or show kind of piggybacks off Dr. Goad's data, looking at the difference in kind of what happens to patients who are vaccinated versus unvaccinated patients. This is from the CDC just about a week ago in their morbidity mortality report. Looking at hospitalizations they looked at 13 jurisdictions across the country, and they looked at patients hospitalized with COVID. It was a mix of those hospitalized for COVID and those who just tested positive. But it's pretty striking when you look at the differences in hospitalization numbers. So this is broken down by age if you're interested, but I'll just focus here on the all ages category. And you'll see that of those patients hospitalized, the vast majority of them, well over 90% in many of these, or around 90%, are unvaccinated patients. Right? And you'll see there are some who are fully vaccinated who get hospitalized. Again, that could be for COVID or it could likely be for other reasons, and they just tested positive. This looked at 2 time ranges. This was April to June in the top half, and then June to July in the bottom half. So you can see a little bit of drop off here, but this is not necessarily the full data set that we would make, decisions in terms of boosters based off, but it does give you some sense that the vaccines are incredibly powerful and useful in keeping patients out of the hospital. And they're holding up pretty well so far, all the way up into the data in July. So again, it's pretty striking the difference in numbers of those hospitalized who are not vaccinated versus those who are. When we focus in a little more on California, this is looking at COVID-19 associated hospitalizations across California on the left in that graph. And it's pulled out by age group. So you'll see the greater than 65 is in that kind of red-orange color. The darker blue is 50 to 64, and then 18 to 49 is that lighter kind of teal aqua color. And then under 18, you'll see the black dots on the bottom. I think one thing that is particularly interesting here is if you look at the difference in our winter surge, that big spike in the middle of the graph, and you follow these hospitalizations by age group to our kind of what we might call our Delta surge right now is there's a huge reduction in hospitalizations in our 65 plus populations. Even though those are the most vulnerable patients, as Dr. Goad mentioned, the vaccination rates in that group are so high, there's a profound impact there, right? When you look at the younger age groups, you'll see that our hospitalization rates for those patients are similar to our winter surge, right? And this is with the vaccine available. And I think this speaks to that difference in vaccination rates across populations. And that, are we seeing more younger patients this time? I think yes, in terms of proportionality to our older patients. We are seeing younger patients in the hospital, but really we're seeing a lot less older patients because their vaccination rates are so high. When you look at Orange County on the right, we follow similar trends as I think people have noticed as California and the country. And again, you can see our current hospitalization patients in Orange County. This is pulled from the California Department of Public Health and their data. And so the hospitalization rates are significantly lower, but I think the big point here is in the elderly population who are getting vaccinated at a higher rate. There's a big difference in those hospitalization rates. So the last thing I wanted to talk about is the therapeutics that we have for COVID-19. And this has evolved seemingly, daily as we've dealt with this since March of last year. What I have on the left are options for patients who are not hospitalized. Any bolded medication here is one that has received the emergency use authorization by the FDA. For those unfamiliar, that's kind of a fast track, not a full FDA approval, but it allows for the use of these drugs in very strict criteria because of the extraordinary circumstances we're in, which is this pandemic. We have looked at many options since March last year, and I can tell you hydroxychloroquine was something we thought might work and we were using. But as the data evolved and as we learned more about it, we quickly found out that it did not help and we stopped using it, right? And so therapeutics has evolved, again, constantly over the course of time. When you get to the hospitalization portion, we have a handful of medications that we are using in the hospital. Those bolded there, those that are typically being used. Only one drug here has been FDA approved, and that's remdesivir, which many people are familiar with now. But one thing I want to say as a whole here is the impact of these medications on your outcome as a hospitalized patient pale in comparison to what the vaccine does. So remdesivir, for example, the data tells us that it probably helps you, increase the speed of your recovery, but it has little, if any, impact on decreasing your chance of dying from COVID-19, right? Whereas we've seen with the vaccine, your chances of dying are magnitudes lower when you get vaccinated. Dexamethasone is one that we've used for a while now, and that one actually does decrease your chance of dying. But again, you're talking about maybe a drop from 40% to 30%, where vaccines, drop it much, much more. So we have some therapeutics that are available now. But again, their effects are nowhere near what a vaccine can do. And all of these drugs are going to have side effects that are likely going to occur at a higher rate than the vaccination that you would get. And I think on top of that, the concerns about, do we know enough about the vaccines? Is it still experimental? The studies which approve these drugs are often in the hundreds, maybe the thousands. We may get a big study that's a couple thousand versus a couple thousand, where the vaccine studies are in hundreds of thousands, and we have millions and hundreds of millions of people vaccinated at this point. So the data driving these decisions is much less robust than the data we have with vaccines. So I'll stop there, and we can move on to the next part with questions. Thank you.
Great, thank you very much, Dr. Fong. And you have all given us a lot to think about. We've had a lot of great questions posted by our attendees also. Thank you all for doing that. And I think I want to jump right into question and answers now for our panelists. And I'll direct some, but then also open these up to any of the panelists, actually, because there's a lot of great questions here. And I think you might have touched on this, but I would be interested. I think the question has come up, and we hear a lot about this. This is both a public policy issue, but I think it's a societal issue too. The idea around vaccine mandates, we're hearing more and more about this. I think initially there was some hesitation in doing this, but I think we're hearing more and more about this. I guess there's a couple parts to this. where do you all see this going in terms of increasing in vaccine mandates, whether that's in businesses or different event settings or different places where people want to go travel? And then the second part that some were asking in terms of, is this strictly just a public policy decision, or does the public have a role in kind of forming those types of decisions also? Jeff, you want to maybe start? And I'm sure Michael has something to say about this also. Yeah.
Sure. Yeah. No, I think, this has been a hot topic, not only here at Chapman University as we think about our sporting events and indoor classroom spaces and things like that. But, the United States in general is facing a lot of interesting issues around vaccine mandates. And keep in mind, we've always been hesitant to do vaccine mandates in the adult population, right? For example, even hepatitis B for healthcare workers isn't optional, right? You have to decline it, right, if you don't want it, but it's optional. But what really has moved the needle for vaccination rates, at least in the pediatric population, mandatory childhood vaccination for school entry. So I really don't see a way out of it without vaccine mandates or an increased use of vaccine records to access places where large people gather indoors together. I think using vaccine records is really important, but I think the important part about that is to use the official record. As counterfeit cards are all over the internet, you can't counterfeit the California Immunization Registry. And we have an easy tool. We need to see more businesses and places using that tool than a tool that's easily counterfeited.
Anyone, Michael, you want to add anything to that, or Jennifer or Gary?
Here we go. Yeah, I think, again, there's a lot of misunderstanding involving this word mandate. Private corporations should be free to do what they want as a general principle, and most are moving in the direction of requiring their employees to be either vaccinated, double vaxxed, or tested 2 or 3 times a week. Who wants to do that? So that's kind of an internal pressure to get vaccinated. And they kind of have to do that. Like Chapman, you have legal responsibilities. And if, some student dies of COVID on campus, there's probably going to be legal ramifications. And I presume most corporations worry about that sort of thing, or places like Disneyland or whatever. So I think the problem may solve itself just that way from the bottom up. But of course, when we expect our public health to be guided at least by government agencies, and therefore that inevitably comes up. The idea that this never happens is not true. I was in my article on this subject, I quoted Representative Marjorie Taylor Greene, who at a campaign rally in Alabama told them that they were lucky they weren't vaccinated, and because Joe Biden wants to come talk to you guys, she warned them. What they don't know is in the South, we all love our Second Amendment rights, and we're not really big on strangers showing up on our front door, are we? Now, was she really suggesting that people shoot government agents that come to their doors to ask if they've been vaccinated, as if that's even going to happen? Well, I don't know. She's waving the red meat. But in fact, it's not true. I'll just read a quote here from an appellate attorney who wrote an article about legal decisions in the past. Every school district in every state in America requires children to be vaccinated to attend public schools. Most states offer exemptions in some cases, but there's no question that states and school districts have the legal authority to demand that school children be vaccinated. And this guy, Chris Truex, tracks the legality of vaccine mandates back to 1905. The United States Supreme Court determined in Jacobson versus Massachusetts that, quote, mandatory vaccinations were perfectly constitutional and an important tool of public health. Henning Jacobson, an early anti-vaxxer, refused to be vaccinated for smallpox. Just like anti-vaxxers do today about the COVID vaccine, he argued that the smallpox vaccine didn't work. The court determined otherwise, citing with high medical authority that vaccines do in fact work. Pithily restated by Truex thusly, quote, "We all know vaccines work and the medical profession as a whole accepts that vaccine work, crackpot theories to the contrary notwithstanding." So there are legal precedents for this. Yes,
All right.
okay. Yeah.
Well, thank you. And that's it gives a good perspective on mandates. I want to shift some, maybe more on the science side. As we hear more and more about variants and also the effectiveness of vaccines and boosters, what do we anticipate the need of the development of new vaccines or the changing of vaccines to in response to the different variants? Also, do we anticipate any new vaccines coming out because of the way COVID-19 is changing? So maybe I'll start with Jennifer, since she's our immunologist here, and if others want to weigh in on this.
Sure. So like I sort of covered in my remarks, the response against the spike protein identifies multiple regions of the spike protein. And so it would actually take a lot of mutation in order for that protein to really look substantially different from an immunological perspective. And I know that that both Pfizer and Moderna are currently formulating vaccines that have the new sequence for the new spike variants. From an immunological perspective, I see that as very likely going to boost the existing response as opposed to creating a response that is really appreciably different versus the original vaccine.
Anyone want to add to that, or?
And I agree. I think also, Jennifer points out, immunologic standpoint, it does make sense to use the existing vaccine, but also the data itself suggests that, our vaccines are still holding up. I mean, look at the protection for hospitalization and severe disease, even in the face of the Delta variant. So I think boosting the existing immune response for people who have waned makes a lot of sense.
Great. Maybe going to direct this next question to Gary. We hear a lot about, people want to trust the science around this also, but you're on you see people in the hospitals, you see people in the clinics also. Can you maybe speak some about, you did speak some about in terms of, treatments and what you're seeing in the hospitals also, but speak some about kind of the people, the way people change their minds about getting the vaccine by information that they're getting from trusted sources. And when I say trusted sources, certainly public health officials are part of that, but are there other trusted sources that you're hearing that people are changing their minds, that may be vaccine hesitant, that changes their mind about getting the vaccine?
Sure, yeah, I'd be happy to talk a little bit about that. I think one of the challenges in with the population that remains unvaccinated is you have a portion who are staunchly against it, no matter what you say, what kind of information you provide, who it's from. But I think there's still a group that sometimes just don't know enough. They don't listen to the news every day. They go to work, do their thing, and they don't really realize it until it gets close to home. And I think that's the population that we would love to get to some way, right? Someone more local, someone more personal. And I think we see it in the hospital in cases where, we'll have a couple who are, the husband, for example, may be hospitalized with severe COVID, unvaccinated, but the wife is vaccinated, right, in the same household. And it's not a matter of, the husband being an anti-vaxxer, just a matter of the wife knew someone who told her that, hey, you should come get a vaccination with me, or she had the time to. And the husband just didn't think much of it, right? Until now, it's really too late. And as you've probably seen on the news, patients who get hospitalized who are unvaccinated, many of them really regret their decision to go unvaccinated. So, I think we have a lot of the top public officials trying their best, presenting data, trying to, speak in a way that will get to people. But I think at the end of the day, to get to a lot of those who remain unvaccinated, it's the personal stories, it's the personal touch, it's the local people, and finding a way to get out there probably is going to have more effect. Because I think many of the people here, and obviously the ones speaking, are very plugged in and tuned in on what's going with COVID. But there's still a chunk out there, I think, who just unfortunately have not had the time or the ability to go learn as much as we would hope they'd be able to.
Anyone else want to add to that in terms of what do people view as trusted sources of information that kind of changes their mind about vaccine hesitancy?
Yeah, I can address that because we deal with that a lot. There's been an erosion of trust in science. This is my main focus. Scientific and medical institutions were always highly trusted in, surveys going back half a century. That has eroded over the last decade or so, to the point where some people think we're living in a post-truth world, with fake news and alternative facts and all that stuff. I'm not sure it's that bad. I mean, the people that claim we're living in a post-truth world would themselves have to make a set of arguments in which they're using reason and rationality to argue that reason and rationality are not useful anymore. So I think that's somewhat self-contradictory. But the point that, at least in the public perception, particularly in the media, that you can't trust these people, meaning like people like Dr. Fauci. You hear this a lot. And again, a misunderstanding of how science works. In politics, if you change your mind, you're a flip-flopper. You're no longer part of our team. It's a team effort, and we have a set of criteria that we stand for. This is what we stand for. And if you veer too much from that, or you change your mind on them, then you're not a part of our team anymore. It doesn't work that way in science. At least it's not supposed to. I was at a conference recently in which one of the speakers was talking about a paper published in JAMA, the Journal of the American Medical Association, 1989, claiming that the HIV virus could be spread through the air and through water, swimming pools. You could catch it on a bus, this kind of stuff. And people were, of course, rolling their eyes going, how dumb is that? And then he drops the other shoe. And the author of this paper was none other than Anthony Fauci. And everybody's like, oh, that guy, oh, he's always wrong, and he's always changing his mind. And then this guy even said, and then he retracted that paper a couple of weeks later when it was determined that HIV cannot be, transmitted that way, as if that made it even worse, that he retracted the paper because new evidence came in. And of course, I spoke next and said, no, actually, that's how it's supposed to work. You're supposed to change your mind when the facts change, but people think of this more as a political thing rather than a scientific thing. And therefore, changing evidence that leads to changing minds is not part of the normal formula. So again, we have to combat that.
Can I say something just briefly before we move on?
Yep.
With regards to evidence, I say this to a lot of vaccine hesitant people that I interact with online and social media. Look for the evidence, right? You're going to hear who you're going to hear based on what your media is showing you. But pay attention to who is saying, this is just how it is because I said so, and who is providing you evidence to support what they're saying. And I think that's actually a really, really important tool for people who are trying to do their own research on this topic to always keep in their mind.
So that's a good lead into my next question, Jennifer. So thank you. There was a question posted around, is there evidence that natural infection is more effective or durable than the vaccine? And I think we hear this sometimes in terms of why people don't get the vaccine is because, well, I've had COVID previously, so why should I get the vaccine? So what's the thinking? What's the evidence around that right now?
So a lot of the people who are saying this are referencing data from Israel, showing that people with 2 doses of vaccine were more likely to get a breakthrough infection than people with natural infection. But what they actually miss a lot of times in that data is that the people who are least likely to be infected with COVID-19 in that study were people who had a natural infection and at least 1 dose of vaccine. And it goes back to what I was saying in my remarks, that your immune system pays more attention and just commits more resources to remembering things that it's seen more than once. So 1 natural infection is going to be like 1 vaccination in that it's 1 exposure, and your memory of your immune system to that exposure is going to wane over time. But if you remind the immune system, hey, remember this thing, it's going to remember it better. Remind it again, it's going to remember it better. That's how the immune system works. More memory associated with more exposures. And the other thing that really leads into this that we don't have a lot of research to support, other than just things that we know as virologists, viruses really muck around with the immune system while they're in there. this is happening a lot in severe COVID. I'm sure that Gary can talk about this, that this virus is just messing with your immune system while it's in there. And during that process, it's actually kind of making the response suboptimal. Whereas a vaccine is very targeted to just generate a very specific response and not mess with the system like a real virus infection does. So particularly for people with severe infections, their immunological memory against that infection is highly variable because of the effects of the virus itself in combating the immunity during the infection.
Anyone want to add to that? Gary, you want to maybe add?
Sure, yeah, and I think we've seen some of this mentality of, I'm relatively young and healthy. I'm going to get COVID anyways. I'll just do that and get my immunity that way, and then forget the vaccine, right? And I think it certainly could happen, and you can get COVID and be fine, and you have some immunity. Because as Dr. Totonchy mentioned, that second dose is important to really give you full protection. But I think, as Michael Shermer referred to too, is there's a risk associated with getting COVID, and it's not just dying. We will have patients who they get COVID, they get a mild infection, and they may lose their sense of taste and smell for months or even longer, right? And is that going, it's not going to kill you, but that's probably not something you want to deal with for an extended period of time. We have patients who, as many have heard of, are long haulers who get COVID and have to deal with symptoms, some mild, some pretty debilitating for months on end. And do you have some immunity now? You probably do have some immunity, but you are now stuck with that gamble you took in getting COVID, naturally versus a vaccine. So again, I think there is that risk involved in getting COVID. It may be small, but if you're the person who ends up getting hospitalized, getting really sick, getting the long-term effects of it, it really didn't pay off when you have an alternative that has now really been proven to be incredibly safer than getting COVID itself, right? So I think that's something we see in patients who will get rehospitalized with second infection who never got vaccinated. And again, it's kind of, I wish I had done that, but now it's too late.
Thank you. I'll maybe start with Jeff on this question. As we move into flu season, and we're hearing it's that time of year to get flu shots, and I think, and maybe you can correct me if I'm wrong, but I think last year a lot of people didn't get the flu shot. But what should people be thinking about this year as we move into the flu season and getting the flu shot? Have things changed at all in terms of the thinking around that now?
Yeah, no, from the perspective of flu, I mean, we've been COVID. We haven't really thought about flu, but flu hasn't gone away. When everyone stays indoors, wears masks, and stays away from each other, it goes down, right? But unless we're willing to, kill every pig bird on the planet, we're never going to eradicate influenza. It's going to be a human disease with us. So although the numbers are down, it will come back, right? And one of the things we like to talk about in the influenza world is kind of building up your immunologic store, your antibodies against this disease year after year. So skipping a year, your antibodies might dip down low so that maybe when we have a bad season, you're not going to fare as well. So we recommend people get flu shots every year to keep that immunologic response up and healthy. And in fact, last year, actually, it's maybe counterintuitive, except the way that the campaign went last year. Some of you might remember something called the twindemic, right? Which is how public health was using that campaign to put together COVID and influenza. And so actually, we gave out more influenza vaccine than we had in the past. We made more, we gave out more than we ever had, which was pretty amazing. So we know that the system can handle that and do that. But I am a little concerned for this fall. When people see in the previous season that there was very little influenza globally, it means that we're going to have a rough flu vaccination season. In other words, giving flu vaccine to people. But I would encourage them to get it. There was a question about, can you get them together? Absolutely. Same day, one arm COVID, the other arm your influenza, and your body can handle that just fine.
Great, thanks, Jeff. I want to ask, and we're not necessarily asking for medical advice here, but I think we're more, as Jennifer said, more asking for, is there evidence around this? I think many people that have young children, and particularly young girls, and particularly teenage girls, is there evidence around that people should be concerned about, that we've seen in terms of that they should be concerned about having their teenage children get the vaccine? Because I think some of this information has been out there, whether it's true or not, I think is what people are want to know.
There is no evidence that I have seen that any vaccine can cause infertility in humans. This story, I think, started with the human papillomavirus vaccine, and people thought because that's a virus that affects the reproductive system, that maybe the vaccine would also affect the reproductive system. There's no evidence that that vaccine affects fertility. And in fact, that's really not how immunology works. And there was a theory very early on in the pandemic that was put forth by somebody with no expertise in immunology, that there was some cross reactivity between the spike protein and this protein that's essential in humans to make a placenta. But anybody with any basic knowledge of immunology looked at that and said, this is ridiculous. There's no scientific basis for that theory. It was just something that somebody made up to try and make people afraid of taking the vaccine.
And just to add to that, it's interesting, in the original licensure study for the Pfizer vaccine, more people got pregnant who were vaccinated versus unvaccinated. So not really sure where that came from. But we also have a very robust pregnancy registry, and there's been no safety signals, no signals of teratogenicity or any fetal harm. So we think it's a very safe, and that's why ACOG is also recommending that pregnant women get the vaccine.
Thank you. Michael, I know you need to leave here in 2 minutes, but I want to give you a last word, and maybe one question I'll ask you, and then any final words you give. What is one myth that people would be surprised to know that they don't know about this right now? And then any final words that you might have in terms of people that are vaccine hesitant?
Probably the biggest myth would just be the same that it's always been for these kinds of hysterias, that you've misplaced your risk analysis, that it's the disease you should be worried about, not the solution to the disease, not the vaccine. But that happens a lot, and even when it gets debunked, like the vaccines cause autism story that erupted in the late 90s after this guy Wakefield published his paper in the Lancet, subsequently withdrawn, subsequently exposed as fraudulent, and he lost his license and so forth. That has been hard to eradicate. We still are dealing with that, over almost a quarter century later. And so the things we're hearing now there's really nothing new. It's just variations on the same kind of fears people have. It is hard to eradicate. You just have to keep pounding away on it. Again, I think the biggest obstacle, though, is this more political and people's misperception of what it means to be free to do what you want. That's not what freedom means, not in a civil society. The right says right there in the Constitution that, that it's designed, here, I'll just read you that. It says here, we the people of the United States, in order to form a more perfect union, establish justice, ensure domestic tranquility, provide for the common defense, promote the general welfare, and secure the blessings of liberty to ourselves and our posterity, do ordain and establish this Constitution for the United States of America. Well, it's hard to be free when you're dead. Okay, so get vaccinated. That's the freedom, liberty, conservative, Republican, all-American, flag-waving thing to do. Get vaccinated.
Well, thank you, Michael, and thank you for joining us. Really appreciate it.
All right. Bye-bye, everybody.
I want to give our other panels, we're coming up to the 1 o'clock hour here, but I want to give our other panelists one final last word. So I'm going to, and really just any final parting words from your own expertise, and final things people should know about that may be vaccine hesitant, or those that may be talking to people that are vaccine hesitant. So I will go ahead and start with Gary.
Sure, yeah. Obviously the plea is to get vaccinated, right? And I think one thing I try to tell people is the number of people you can help beside yourself by getting vaccinated are probably more than you think. The people around you, your loved ones, the ones you interact with on a day-to-day basis, but it's the healthcare workers and the people who work in industries as well other industries as well. You know, in the hospitals, we've been at this for, I think, 20 months now. And it's been tough, and especially with the surges, but even without the surges, even now the numbers are better, but healthcare workers are exhausted, and they, you know, have been dealing with COVID all this time. They want a break, and I think we get a break and we get another surge, and it seems like we have something so readily available that can really squash this. And it's incredibly frustrating to see that we just aren't able to do it as a collective group. So again, I think, you know, think about those that you can help by getting vaccinated, even if it's just not for yourself. And maybe that can convince some people that vaccination, if anything, is something you can do for others along with for yourself.
Great. Thanks, Gary. Jennifer, any last words?
Yeah, we were concentrating a lot on evidence in this panel, and that's one of the things that I hear people say, that that these vaccines are based on technology that is too new, and we don't have enough information about them. And at this point, that is just 100% wrong. The full approval, FDA approval of the Pfizer vaccine, and the forthcoming in the next few months full approval of the Moderna vaccine is actually based on more scientific data than any vaccine approval has ever been based on in the history of vaccines. We know more about these vaccines because they've been under EUA and they've been given to so many people. And similarly about this virus, so many people have been infected and affected by it that we have really just immense amount of data and evidence that COVID is dangerous and the vaccines are not.
Thanks, Jennifer. And Jeff, you get the very last word.
Great, thanks. I would agree with all of those. I think, you know, we've kind of come to vaccines as the way out of this, but I want to remind people, right? If you remember in the 1950s, Jonas Salk, Albert Sabin into the 60s, these were heroes, right? These were scientists that were heroes. We've forgotten that. This is an amazing achievement that we've done in a short amount of time. It didn't take decades like it did for polio vaccine. We did this in a very short amount of time. Americans and the world should be proud of the vaccines that we've created, how safe, how effective, and how they'll lead us out of the pandemic. I think people are looking at this wrong. This is something you should be proud of and jump in line to get it as fast as they can.
All right. Well, thank you to all the panelists. Thank you to all the attendees for joining. I hope you learned a lot today. I certainly learned a lot. Thanks to Joey Anderson, Terrence Stroop, and Pamela Zell for working in the background and helping with all the logistics. And I hope you all have a great day and be safe. Thanks so much.